Tonight's presentation will be the update on the 2013 PCRI conference, and with that I will ask Stewart Campbell to come up, start off the presentation and introduce the other speakers.
So, what are we dealing with in terms of this Prostate Cancer Research Institute? It's one of the largest, if not the largest, conferences that deals with clinicians talking directly to patients in the language of patients. And they're clinicians that come from across the United States and occasionally from Canada. They are very significant individuals in their own right, and each of them are motivated to basically help the patients understand their treatment options. They believe strongly that the patients should be empowered, knowledgeable, and prepared for their discussions with their own local oncologists. And that's what is achieved through all the programming that the Prostate Cancer Research Institute executes. They have a tremendous website and very well worth your visitation on that site and to spend time. What is the name of the website? PCRI.org will get you there. Now, they are strongly in favor of categorizing men by their stage of disease. And they have their own methodology to do that, and it's called, "What's Your Shade of Blue?" And as you begin to go through deciphering the shades of blue, so I reviewed about PCRI. I won't go through that again. I reviewed about what's your shade. So the way that they look at this disease is to categorize it by various colors: sky teal, azure, indigo, and royal. And as you go down that column, the disease becomes more significant, more aggressive, more progressive, and more lethal. And the ABN is simply an abnormal PSA. So this could be a circumstance where there is metastasis, but there's no PSA actually being expressed, and that can happen. So I'm not going to spend particular time on this slide, other than encouraging you to go to the website when this is posted and just try to understand the significance of the terminology of local therapy, Gleason score, percent scores, the digital rectal, PSA, MRI, CDU, CT scans, and bone scan, and as you increment through that. With our group that are speaking today, quite by coincidence, we're covering almost the entire spectrum of these particular shades of blue. And I'm going to introduce now Dave Lunn, who will speak to his own particular journey with prostate cancer, and then speak to a topic that he found particularly and interesting, relevant to him. Dave?
Thanks, Stewart. Thank you, Stewart, and welcome everyone. And, let me begin by saying, well, first of all, I'm a retired biology teacher, high school biology teacher, and have done some writing and attended many conferences. And this one in particular, I would say, is probably one of the best conferences I've ever attended, both in the information that is given and the quality of that information, and as well as the organization. Now, specifically, my situation in terms of my prostate cancer is I was diagnosed in 2006 I was 63 at the time. I was at my family doctor for a routine annual medical checkup, and he did a digital rectal exam and then a PSA test, and he said with the digital he could tell that there was something there. I probably called it a nodule. He got me into rapid access with the Prostate Cancer Center here in Calgary, and then March I had another PSA done, and then subsequent to that a biopsy. My PSA was 7.7, my Gleason was 3+4, and showed it to be adenocarcinoma, which is simply meaning a cancer in the gland, or a glandular cancer. Of 7 out of 10 core samples were positive. The DRE that the urologist did said he could tell that there was a nodule at the base of the prostate. In April, I opted for a radical prostatectomy and done laparoscopically. And my situation today is that I have an annual PSA done, and it's currently undetectable. I have mild stress incontinence, and I have no erectile function either with pills, any of the pills as it turns out, but trimix injection does work. And any of you met Dr. Lee at the Prostate Cancer Center, I think he's instrumental in giving people information, or giving men information about that. What would I have done differently? My opting for a prostatectomy was probably done without a lot of consideration, perhaps, other than I remember saying to the urologist that first of all, let's get the cancer. And let's hope that the incontinence is not too much of a problem, and lastly, erectile function. What would I have done today, having, being part of this group as well as the prostate cancer? I drive the man van, and so involved with the screening aspect there. I probably would have taken a bit more time to do some research as to what the other options available to me presented, and that I didn't do. However, as I say, I'm currently my PSA is undetected, and I'm healthy in that regard. My topic is PSA screening, and just about that, we attended. Two talks, one by this Timothy Wilt, who's a member of the U.S. Preventative Services Task Force, and he's against PSA testing, at least in a mass screening format. The other one, Mac Roach, who's an oncologist, is for screening. And so let me go through those. The conclusions that we can draw from Timothy Wilt was that the testing results in overdiagnosis and overtreatment for most men, and it doesn't differentiate between fast and slow-growing cancers, and that the actual test has only resulted in a small reduction in the number of deaths from prostate cancer. I should have said at the outset that this whole topic of to screen or not to screen is a bit of a minefield, in the sense that there's conflicting evidence, it would seem, and also there's a wide difference of opinion, and I think at the conference, and maybe Stewart and Ron and the other speakers, Bob, would bear witness to this. It seemed to me that there was more favor for having screening done, even though it be done perhaps on an individualized basis as opposed to mass screening. One of the problems is that the PSA can produce false positives, and that leads to more testing, and this comes to the business of overtreatment, which is biopsy, and biopsies can be problematic in the sense that they can have complications, as you see down at the bottom there. The arguments for is that we're looking at early detection if you use the PSC and the digital rectal exam, and if you started men started in their 40s, which of course is the recommendation from the Prostate Cancer Centre here in Calgary, is that you establish a baseline. In other words, it's expected that as men age, that their PSA value will increase. And by having a PSA done in your 40s, you're going to establish that baseline against which further testing can be compared. The screening should avoid over-detecting cancer in men who will not be affected. And in the case of a US study, the screening reduces prostate cancer mortality by nearly half in 16 years. That this has been found that in 1994 in the US there were 39 prostate cancer deaths per 100,000 men, and in 2010 there were 21, and so that's a significant reduction. And the alternatives to biopsy include free PSA analysis, as well as looking at prostate PSA density, as well as velocity. Velocity being the rate at which the PSA value is changed over time. The American Urological Association and Cancer Association both do not support prostate cancer screening in a mass sense, but they do support it on an individualized basis. And they suggest age 55 or over for the Urological Association, and the Cancer Association, they suggest age 50. And the ones that are against the mass screening, of course, are the ones that you see listed there. The Canadian Cancer Society is one perhaps is worth some comment, in that they are against mass screening, in the sense that mass screening would be where you're looking at testing a wide segment of the population, as opposed to making it individualized and having men do it in an informed basis through appropriate counseling. What does Alberta Health say? They suggest that it's a good idea to have PSA tests for men age 50 and over, and their study showed that, and this is I think 2009, information that of 1,410 men that were tested over 9 years, and then subsequent of that 48 were treated, and that resulted in one prostate cancer death being prevented. And the same information for the other one, only the difference being that it was a smaller sample of individuals, and they were tracked for 14 years. And subsequent to that, 12 were treated, and one prostate cancer death was averted. The recommendations, of course, from Prostate Cancer Canada is that men establish a baseline at age 40, and men with high risk. In other words, there's they have a relative, a first relative, such as a father, a grandfather, uncle, that they should then be screened and have a PSA test. At age 70 and over, the PSA testing is not suggested or not recommended, particularly for men who have a life expectancy of 10 years or less. The Prostate Cancer Centre here in Calgary is a PSA test for every 5 years for men in their 40s, and subsequently have it done annually for men in their 50s up to age 75. Alberta Health Services, I've listed their recommendations there. They don't recommend mass screening, but support an individualized approach, as I mentioned earlier. And they're suggesting that it begin at age 50 and once every 1 to 2 years. High-risk men, I mentioned the family history of first-degree relative, or men of African-Canadian descent are also at higher risk, of course. I'll finish up with a listing of websites if one wants some further information about this. These are some that I found and in putting this information together, and some that you would find useful, and I'm sure some of them you've already been to. Ron's going to come up and give his part now. But anyway, thank you.
Okay, you've got a screen there that tells you my history. Some of you have heard it last year or other times. My father had prostate cancer, was treated with radiation. I think he was diagnosed at age 78, and probably today he wouldn't have been treated at all. In any case, I started as early as I could getting PSA, so I'd have a good time series, and you see the range of results. And in, I guess it was 09, I guess it was late 08, my PSA was up to 7 point something. Doctor sent me to a urologist who ordered up the first biopsy, and you see the results there. And when I got the results from the urologist, his recommendation was to me, his question to me was when. That as far as he was concerned, it was a slam dunk, radical appendectomy, radical prostatectomy, and it was just a matter of when to schedule it. Fortunately, he did send me to the Rapid Access 2 clinic of the Prostate Cancer Center. I guess it was the Prostate Cancer Institute then. And everything I saw there in literature and talking was, hey, I was a classic for active surveillance. And I had the good fortune to get a second opinion from another urologist who looked at my numbers and said, yeah, you are classic for active surveillance. So in the course of the active surveillance, I had a second biopsy. And any of you who had biopsies, you know you get the informed consent that says 5 out of 200 have severe reactions to the biopsy. But I'd had one before, so I'm not part of the 5 out of 200. Wrong. And as Stewart has captioned there, I had the biopsy from hell. I had a massive blood and urinary infection, ended up in the Rocky for 4 days, and it took about 6 or 8 months before I was back to myself. Had a third biopsy in May of 11, and whereas I had one core, 1 out of 10, they only did 10 in those days. A third biopsy, I had 0 cores out of 10. Cancer hadn't disappeared, but that's part of what I'm going to talk about, is the random sampling that we do in a traditional biopsy is a bit of a crapshoot. The potential for sampling error, for missing or focusing on areas of high concentration are there. And I think that's the basics of my history. I switched recently from the original urologist to another urologist who was a fairly senior man at the Prostate Cancer Center. And though he's a good surgeon, he runs an active surveillance clinic, which I'll be attending for the first time on January 23rd. So that's the history. Now to go to PCRI, and I'm going to cop out a bit. Stewart didn't tell you that normally when we do this presentation each year, we have a bit of a crib sheet. We have the DVDs from the sessions. They were supposed to be ready in December. They weren't. So I and all your other presenters are winging it based on skimpy notes we took, assuming we'd have our little crib sheet, but we don't. So that being said, a general impression that I got, particularly attending the active surveillance sessions, was a very, very high level of antipathy and hostility towards biopsies amongst the American attendees. You know, though I've told my story many times of my biopsy from hell, one of the people in the early breakout sessions for active surveillance had bigger horror stories to tell. And he had these horror stories despite that he came to the biopsy with all the advantages. Why? Why did he have all the advantages? He was a physician. But his horror story of biopsy was really quite striking. You know, I'll presume that he was given favorable treatment such as all physicians give to their brethren, but you know, it is a crapshoot when you have biopsy. So now we get on to what I've been assigned, and I guess I'm supposed to flip to the next screen, is the live on stage prostate biopsy at the PCRI conference. So it wasn't on the stage really, but we did get to see the left cheek of two gentlemen who were in a ballroom across the hall from the main ballroom. And there Dr. Bond had set up all his hardware and talked and walked us through the color Doppler biopsy. And he showed us some of these images such as you see here. And the software is basically programmed to show you what are likely hot spots. So you see the red areas in the color Doppler ultrasound. Those red areas are colored red because what they show is areas of high blood flow. And prostate cancer cells, as any cancer, tend to seek out blood sources, to feed them, to keep them lively and vibrant. So with the color Doppler ultrasound, Dr. Bond, and there are other physicians, particularly in Southern California, that use this technique, they can identify the likely areas for investigation by biopsy. And with these two patients across the hall, Dr. Bond did this. I should mention that though there were two patients who we didn't know who they were, all we knew was what their left cheek looked like. One of them could have been the chairman of Prostate Cancer Network, Prostate Cancer Canada Network Calgary. Our esteemed chairman volunteered for this, but he wasn't lucky, if the term is correct, to be chosen. So we had two other cheeks to look at. And in any case, Dr. Bond, went in with his probe, and had these images which were picked up and shown in the main ballroom. And based on what he saw, he then did the actual biopsy. But whereas we do here formerly 10 cores, now we do 12 cores, and we do them on a random basis and hope we're hitting the right area. Because he was identifying the more probable areas, he was comfortable with only doing 3 or 4 cores. So in terms of what I referred to earlier, the antipathy, the hostility towards the risk of biopsies, that's diminished, obviously, by doing a less intrusive procedure, a less intrusive, but probably a more likely to be successful probe. So the first patient, patient number 1, the findings that you see posted there that Dr. Bond had was that this individual, as a result of the findings from the pathology, which we didn't get quite on the spot, that he was no longer a good subject for active surveillance. And that was identified by doing these 3 or 4 cores. Patient number 2 what Dr. Bond found with the color Doppler ultrasound biopsy was a very well-defined, what he referred to as an index tumor. But the pathology on it wasn't particularly high. So as you see in Dr. Bond's conclusions, he's recommending that he be kept on active surveillance. But now, having done this first color Doppler ultrasound, they know where to watch. They know where this index tumor is and know to watch how it's growing. So that's what this technique offers, is a very focused, specific way of proceeding with a biopsy rather than what I'll refer to as the crapshoot variety of random sampling biopsy. So that's the technique that Dr. Bond presented to us. And to me, it seems like a good idea to do a more focused biopsy rather than a random biopsy. And though it's used in this fashion, the use of it is relatively new for prostate cancer. In fact, color Doppler ultrasound is used in Calgary at the Rocky View with regard to prostate cancer, not diagnosis but treatment. It's used. The urologist at the Rocky View who practices cryosurgery has a radiologist who does color Doppler ultrasound to provide guidance for him to do the cryosurgery. So we've got the hardware, we've got the practitioners who use it in the setting of the prostate gland. It's probably not a big leap to try to get it used in a diagnostic fashion. I'm saying it's not a big leap, but change in the healthcare system probably doesn't come quickly anywhere. All this being said, there was a breakout session towards the end of PCRI where Dr. Bond presented and other of the Southern California physicians who use color Doppler ultrasound. And in the Q&A, I said, well, what if a fellow wanted to get a color Doppler ultrasound? I asked without a biopsy, because I don't know about you, but if I got any healthcare treatment in the US, I'd probably not want invasive treatment. I'd probably want a diagnostic, but if anything went wrong with an invasive technique, I wouldn't want to be there, because I don't know if any insurance would cover you for as it were, voluntary surgery down there. In any case, Dr. Bond said, no, the only way I do it is the whole meal deal. You do the diagnostic and the biopsy. But Dr. Lamb of the clinic in Marina del Rey said, in fact, they do it. First, they do the color Doppler ultrasound as a diagnostic, and then based on that, they proceed at a subsequent date to do the actual biopsy. So for those who have interest in having it done, you can get it done. Now, there's the leap of, will the people up here read that color Doppler ultrasound? Well, I'm going to be exploring that on January 23rd when I talk with my urologist. Okay, so now, presuming that leap can be breached, I asked the Gordon Sinclair question of Dr. Lamb. How much does it cost? And surprisingly, not all that much. Though first he professed to not have any knowledge, and probably the physicians don't, probably the front offices or the sales and marketing arms. But eventually I got him in a bit of a corner, and he said, probably about, for the diagnostic, about $800 to $900. And if you proceeded a couple of days later with the biopsy, the full meal deal would be about $1,100 or $1,200. So, we're talking about not great amounts of money plus an air trip back and forth to California. So that's it's not beyond the pale to avail ourselves of this kind of technique if we feel it's of interest. Now, as I mentioned, we didn't have the DVDs to prep ourselves for this, but Stewart, being the great internet searcher that he is, found I don't know if it was YouTube, but some other kind of video, a half-hour presentation by Dr. Bond on the color Doppler ultrasound. And it's my intention that at next month's active surveillance and newly diagnosed meeting to show that. So if those of you who have more interest in this, we can talk about it next month. A couple of closing remarks. Though David gave the very comprehensive discussion of the Preventive Services Task Force report, I think we shouldn't focus too much on it because it's something that is much more relevant to the American setting. A, it is a U.S. task force. B, it's related to its concerns are very relevant in the context of the for-profit model of the U.S. healthcare system. That, mass PSA screening can easily be turned into a way of cranking out surgeries and other therapies. Last couple of things. Other sessions, there were, aside from Dr. Bond's sessions on the color Doppler ultrasound, there was a Dr. Korhanowitz from University of California at San Francisco who really talked about a lot of amazing new things that are coming down the pipe in terms of diagnostic imaging. Lastly, something that seemed to come out, and it came out the year before at PCRI, is more and more prostate cancer is being viewed as a managed chronic disease rather than a terminal disease. And I think that, the degree of positive vibes that come out of PCRI each year are really exciting, and I recommend that any of you who have the interest go down. We haven't discussed it at the board level this year, but I'm sure we'll be subsidizing a number of people next year. So think about it and talk to any board members that have interest. That's my piece.
Hi there. I'm Bob Dixon, and my wife, Sherelle Kopp, is here with me. We're going to do a bit of tag teaming as we talk our part of the story. First, I want to give you a little bit of background. Prostate cancer has been around my family for as long as I can remember, at least 20 years. Both my father and grandfather had prostate cancer. My grandfather was diagnosed. He was well on in age, into his 80s. And the doctor who did the diagnosis told, it was my father who took him in at the time, told him, and Dad said, don't tell my grandfather, because the news will kill him, not the prostate cancer, just the news of it. So I don't think they told him. My grandfather kept on living. He passed away at age 95 of don't know what, but it wasn't the cancer. My father, on the other hand, he also had prostate. He started out with prostate issues when he was in his 50s. But he procrastinated. He put off dealing with those issues. Finally, my mom talked him into going in and getting it looked at. But by then, it was too late. The cancer had already developed, and it had progressed outside of his prostate. He passed away at age 67 of liver cancer, but it was prostate cancer driven, 8 years after his initial diagnosis. From that background, it leads to where I've come from. I've been having the regular checkups, getting my doctor to do the DREs all through my 40s and 50s. I don't think it was annually, but it was on a regular basis. This led to recently an increase in my PSA, and I was referred to a urologist. I had my first biopsy in the summer of 2012, and went back and had another one a month later, because the first one, the results were inconclusive, and we just had to go and repeat it again. That second biopsy, 2 of the 12 samples were abnormal. One of them was 10% invaded. The other one was 20% invaded. This represents 2% of the total core was deemed to be cancerous at T1C staging. At Gleason 6, or 3+3, I was 56 at the time. I've had one biopsy since, that was last summer, and then similar results coming back. I'm currently on active surveillance. My PSA trend has been erratic to a maximum of 6.3. The latest one was 4.4. I have my next appointment next week in the active surveillance clinic, so I'll get another point to put on my graph. This ranking of my numbers makes me a sky on the chart that Stewart put up at the beginning of tonight. Cheryl?
Good evening, everyone. My name is Cheryl Kopp. Firstly, I would like to thank PCCN Calgary for sponsoring me, as well as my partner Bob Dixon, to attend the 2013 PCRI Prostate Cancer Conference. When Bob was first diagnosed and the doctor said that C word, I recall a big kind of sense of fear and disbelief. We talked about it a lot, let it settle in. After it did settle in, both Bob and I started our journeys towards education and knowledge, what we were going to be facing. We're thankful that the cancer has been diagnosed early, and this allows us time to become informed about all the various treatment options should we have to make a decision in the future. The conference was a perfect opportunity for us to gain insight and knowledge that's not easily accessible to us in Canada. The information was all in one location. It allowed us to focus only on the prostate cancer at the conference. We weren't distracted by our everyday lives and things that are happening. We were there to absorb all the information. Being new to that whole idea, the conference was a little overwhelming. It really made me realize how much I wasn't aware of and how much I didn't know. The information obtained at the conference has been very enlightening. It's given me a greater understanding and the ability to ask more informed questions when we go to visit the doctor. I sort of know what I'm talking about now. As Bob's partner, I feel I not only need to be supportive, but that I also have to, and I'm required to be educated and to be involved because I'm also directly affected by his cancer. The treatment choice of active surveillance involves monitoring Bob's PSA level, supplemented by the biopsies. At the conference, I gained information about other monitoring options that are less invasive than biopsies and possibly more effective in determining the extent of the cancer. As other people have mentioned, the biopsy stories were quite frightening at the conference, so I was very interested on other options that we might be able to pursue. There are many buzzwords used by PCRI. In the brochure that we got, they were connecting, education, empowering, options, research, sharing, team, giving, and advocacy. I notice now that my slide is actually missing the word giving. It's actually very important. It should be listed, and it's probably the building block of all the other objectives, because without funding, nothing can actually be achieved. At the conference, though, I learned these weren't just buzzwords. I learned that the meaning of these words. The conference, to me, definitely achieved its objectives, and it provided opportunities in each and every one of those areas. I still think, though, we need to find a way to have the football players wear blue and not just pink. Many speakers at the conference reinforced the notion of taking responsibility for your own health concerns. We've all been trained not only to respect, but to accept the decisions or the options that are provided to us by our healthcare providers and physicians. We need to change our thought processes. We need to ask questions, get second or third opinions, and educate ourselves. The extent to which one participates is solely individual, but that really came across in the conference is we have to take a look at our own health and just ask more questions. The conference wasn't all business, though. There were excursions and there were opportunities for fun. It enabled me to remember that it's all part of life. Dealing with the roadblocks that you encounter depend on your own attitude and your own outlook. No physician or healthcare system has our answers. Those must come from Bob and I as we go through this journey together. After the conference, though, since we were in LA, Bob and I decided to continue the fun part. So we went to Disneyland for 3 days. It brought back the kid in both of us and renewed our smiles. So it was really good for that. I will attend the conference again, and I encourage each and every one of you to get involved and to also go to the conference if you can. Thanks. Here's Bob again.
Okay. The conference had so much. These doctors are the experts in their field, and they often talk way over my head. And I consider myself a little bit science-oriented. I'm an engineer by practice. But this is just so complex in the words that they were using. But one of the things that struck me so strongly is that the investigation of prostate cancer is an evolving science. We're learning more and more each day. And as part of that, one of the things I really took away is that in this business, there are no facts. What you know today will be improved upon or shown to be different by research and progress tomorrow. If you were told that you have a 1 in 4 chance of anything happening, and I'll use the example here of disease progression, the numbers will be different for different age groups, for different disease factors, which we can pick out, and especially for each of you in your unique situation. So if the textbook says you've got 1 in 4, nah, it's not that. You may not know what it is, but it's not that, and it won't stay that. Diagnosis techniques are getting better. All of the old numbers get out of date. Research is constantly revealing new insights, new ways of looking at the progression of this disease, and treatment results are improving. And I may be a bit on my pulpit giving you a sermon here, but I believe every one of us can improve the way you converse with your doctors and other healthcare providers to better understand the words that they use, what do these phrases mean, and disease-specific science. How is that cancer, how did it start in your body, how is it growing, how fast is it growing, what can you do about it? The more of this conversation, it becomes a two-way conversation rather than the doctor saying, you've got cancer, now let's get it out. Get it to a level that you're comfortable with, you'll be improved, or you'll improve your understanding. How? Well, the first step is you're here at these meetings. And so I'd say by and large, you're better educated than the general population. But as everybody speaks of, reading, internet research, going to these conferences, all raise our collective understanding. And with these better conversations with your doctors, you're likely to feel better about your prospects and have a better outcome with prostate cancer. Lastly, I want to talk about biopsies. And you may be getting tired of it because you've heard Dave talk about it, you've heard Ron talk about it, Sherelle even referenced it. It sure struck me that these biopsies are something that we need to, at least I do, have to have a better understanding of. So my last slide, the first part of the last slide, is going to deal with what I call biopsy stories or biopsy anecdotes. They aren't necessarily truths. I've got a bunch of them listed there, and the quotes are around them, because these are phrases that I heard, usually from respected people, but not necessarily in the context of what I might be thinking at the time. 5 out of 200 biopsies have severe infection, 2.5%. I didn't know that when I went for my biopsies. I hadn't asked the question. If I'd been told, it went right through. But it's pretty high. It makes me take note, especially when you hear about the debilitating nature, Ron's case, this doctor we heard about, and others. Gets me a little concerned. Somebody said, do biopsies drive further erectile dysfunction? Well, okay, think about that one. Is there any reason to do a random biopsy again, was one of the questions put to us. Why not always do a directed biopsy? The color Doppler that Ron showed you previously is one way of focusing so that that biopsy needle only goes where you think the most likelihood of a trouble spot is. The other comment, I've inserted the word random here, but because it was in reference to random biopsies, but the transrectal biopsy misses 30% of the cancer. One of the reasons is because the anterior lobe at the back is how I have understood it. 15 to 20% of the total prostate does not ever get sampled with random biopsies. Apparently the guy running the machine is too worried about going right through and causing problems, so he just doesn't stick the biopsy needles there. Ron talked about color Doppler, ultrasound, and there's other means as well of focusing the biopsy rather than doing that random shotgun blast kind of approach. There's also a big long mouthful, multiparametric MRIs for monitoring and evaluating your prostate cancer outside of the prostate gland. That's enough on biopsies. And I want to conclude with two other comments that made me feel a little better about the prostate cancer. I can't call these truths, though, they were just comments. First one, usually Gleason 6 tumors, which is where I'm at, do not grow into higher grade tumors. Well, that's kind of comforting that what I've got isn't going to grow. That doesn't mean there won't be some other brother tumor grow up beside it. But at least it's not all bad news. And lastly, and I've heard this more than once from different places, maybe Gleason 3+3 should not be called prostate cancer. It's an abnormality of the cells in your prostate, but maybe it shouldn't be referenced as cancer. That was these guys' take on it. And I'll leave that with you. That's all I have.
Hi, my name is Willem Smink, and this is my wife Yvonne. We're going to do some chatting here about our experiences with PCRI. What slide is that? Jeez. Not mine. Okay, so first I'll start off with my journey with prostate cancer. I was diagnosed with prostate cancer back in 2007. Usual, I had a PSA testing and the DRE, and it was just routine testing. And what happened was my PSA was at 4.1, and there was a lump in my prostate. So we had another PSA test done a month later, and it had gone up to 4.3, and then another month later it went up to 4.6. So at that point we knew we had 3 rising PSA tests plus a positive DRE. So went in for that whole that famous biopsy that we've just been talking about. I ended up with a Gleason score of 4+3, which is closer to a Gleason score of 8 than 6, so that wasn't very good. There was 10 cores and 2 were showing cancer, and they were like 15 to 20% per core. So I opted for the radical prostatectomy. I was only 56. I thought, I want to get rid of the cancer, get rid of it. So December of 2007, I had a radical prostatectomy. And after that, the PSA was unmeasurable or 0. Having said that, there was a positive margin. But we decided, my wife and I, that it was probably just wait, because every time you do a treatment, there are definitely side effects. So in 2008, the PSA came back. It was 0.02, and it continued to rise. And you'll see in my next graph how it was doing. So in 2009, I went in for external beam radiation during the months of July and August. And because of the external beam radiation, it stopped going up. It went to 0.06, then flattened out for a year, and then carried on again. I did suffer from stress incontinence, so I did try for a male sling. Unfortunately, that didn't work, so whatever. So last October 22nd, I started androgen deprivation therapy. I was on Eligard and Casodex, Casodex just for a month, and I'm still on Eligard. I just went for my blood work yesterday. I will know next week, Wednesday, whether my PSA went down or not. So that's where I'm at on that one. Having said that, just as a brief, my dad did also have prostate cancer, but he didn't get it till like he was in his late 70s, and it wasn't really a big issue. So this is what I looked like with my PSA rising. So you can see in December, radical prostatectomy, and you can see the slope of the line. That slope of the line is the same as the very end slope of the line, which means right from the get-go, my PSA was rising doubling about every 3 months. So it's been pretty consistent. So you can see where the salvage radiation kicked in, and it was flat for a year. And then it started going up again, and up and up and up. And basically the oncologist said, you know, when it gets between 10 and 20, we'll start doing hormone treatment. So, and that's where we're at. And that's why when I went to the PCRI conference, I really focused on hormone treatments, just because of my rising PSA. What am I going to do? What are my options? You know, how's it going to work? So I did a little slide on advances in medical therapies for PSA. I stole all the information off of the internet because we didn't get our DVDs. And basically what it shows that in 1941, your option was castration. It worked, but they didn't know why. It wasn't until 1951 that they figured out it was the testosterone was driving the growth of prostate cancer. And then it wasn't until 1985 that the first of the hormone drugs started showing up. So you get 85, 89 flutamide, 95 bicalumetide, I can't even say them, 2003 zoledronic acid, 2004 docetaxel, and all that kind of good stuff. So over a period of about 20 years, there was, 8 or 9 drugs developed. And this is the exciting part. From 2008 to 2013, they developed 7 drugs. So, I mean, they just about developed as many drugs in 5 years as they had in the previous 20 years. And you get all these drugs like cabazitaxel, abiraterone, radium-223. How do you get my notes out? So far, I've been winging it, but now the detail. So what it showed is that of the 7 drugs, 3 were hormone related, you know, for fighting hormone deprivation. 1 was an immunotherapy drug. 1 was for the treatment of osteoporosis, which is very critical in when you have bone metastasis. 1 was injection radiation, where they put a radium-223 in you, and then it goes to where the tumors are, and it helps. And 1 was on the stopping of cell division. So, for instance, in the list there, Firmagon is a hormone therapy. Provenge is one of the first successful immunotherapy drugs. There's drugs like Zytiga. Let me just step back for a second. When you have hormone treatment, there's 2 ways it works. One is that it stops the production of testosterone, so you get like chemical castration. And the other one is where it blocks the receptors of where the testosterone works. So what these drugs do is some of them stop testosterone, some of them stop at 1 androgen receptor, one of them stops at 2 androgen receptors, and that's where all the progress is being made. So treatment strategy. Unfortunately, with hormone therapy drugs, they work for a period of time and then they fail. It's just the nature of the beast. They'll go from 2 to 4 years. Some people are lucky, it get many years. Some people are unlucky, it only goes for a couple of months. But the latest thinking on all these hormone therapy drugs is to treat sequentially. The theory is that each hormone drug works in a different way, and therefore after one more hormone drug has failed, then the next drug will continue because it works in a different way. So let's say I'm on Eligard. I'm hoping it lasts for 10 years, but let's say it only lasts 2 to 4 years. Well, then the next drug is abiraterone, which instead of being a chemical castration, it stops the androgen receptors, it blocks it, so that the testosterone has no place to work. So then what you have is, you got a series of these drugs, let's say 4 or 5 of them, And theoretically, if they all work 2 to 4 years, you can drag it on for 10 to 20 years, and all of a sudden it's not a big risk. You're managing your disease. The other thing they've been doing, of course, is treating hormone therapy in conjunction with radiation, and a 1997 study shows a lot of benefits for doing this. My take on the PCRI conference was the message I took home is that there's a great deal of research currently being carried out to treat prostate cancer. There is a ton of work being done. There has been significant success with the latest androgen deprivation drugs. I just talked about that, the different ways they worked. There has been some success in using immunotherapy, which is Provenge, which is very specific for an individual. What they do is they take out your white blood cells, send it to a lab, get them sensitive to your particular cancer. They re-inject it back into you, and then it goes right to the scene of the crime and starts fighting your cancer. It has been approved, I gather, from what I saw on the internet, by the FDA. It's terribly expensive. It's $100,000 a shot, so it's not a cheap one. The other one that they've been working on is and by the way, immunotherapy is one of my favorites. I think there is a lot of upside with immunotherapy because they barely scratch the surface. I think down the road, that's probably the way it's going to go, hopefully. The other one I talked about briefly was the radium-223. And what they do is they take the radium-223 and they inject it into your bloodstream. And 223 it gives off alpha radiation instead of the beta radiation, which most of it does. The alpha radiation only penetrates from 2 to 10 cell widths away. So the radium-223 acts like calcium, and it gets picked up by the prostate cancer. And then what it does is it radiates very locally right where the cancer is, right? And you don't have to worry about a lot of tissue damage, which can happen with external beam radiation or some of these other treatments. So for me, the whole PCRI conference was that so many drugs are being, found in the last 5 years, and I'm assuming in the next 5 there will be that same thing over again. And this has given me a lot of hope that cancer growth can be slowed down or stopped from growing for a significant period of time, like I'm talking about years. So anyways, that's my talk. And I'll turn it over to my wife now.
Yeah, that's Willem's story, which obviously also affects me. I'm going to talk about something separate from that, except to, with regard to some of the things that have been spoken about this evening, I have to say that we are grateful that the PSA test was offered to him, and it was offered at his doctor's suggestion, because without that test, we would not have found out that he had cancer at all because there was no symptoms. So as a result of that PSA test that he got treatment. And since this is a fairly aggressive cancer, as you've been able to see, we would be in really serious trouble now if he hadn't found that out. And so I think the encouragement that I also got from the conference was the fact that there are treatments available for him so that, his life can go on and he can be healthy and active even with this disease. I wanted to just talk about the aspects of the conference that were specifically for women. They usually try to include something that is geared just for us. There was a Dr. Andrea Singer who talked about caring for the caregiver. And this is a very relevant topic because some women, depends on the stage of cancer that their husband is in, but they're so involved with caring for their partner or husband that they forget to take care of themselves, and they end up being worn out. So they need to be reminded that they have to monitor their own health and take care of themselves too, so that they can continue to give that support. So that was very valuable. There were 2 peer support sessions for women, and I attended the Sunday session. This was led by Jan Manawright and Imani Lester. This was an opportunity for women to share their stories and to ask questions. These sessions can be vital for people, especially those who are newly diagnosed and have no other support system. The woman's story starts off with her spouse's story, but differs because of the way the menfolk respond to the diagnosis of prostate cancer. I think it's no surprise to anybody to hear that men don't make very good patients. You may not be surprised to know also that some of them are really awful, and that makes it very hard. He's not really. But Willem and I used to facilitate a support group that was connected with this PCCN Calgary. So we've heard quite a few stories, and the conclusion we can draw is that there are many varied responses to the cancer diagnosis. This means that it's really important for the partner, the one that supports, to be able to find support for themselves, and as you've heard from other people's talks, to become informed. Men and women think differently, so when they attend the same session, they're going to pick up different information and come away with what they need, what's relevant to them. So although these conferences appear to be geared for men, they're also very valuable to the women who support them. Imani Lester is the Director of Communications for Women Against Prostate Cancer, and they have compiled a booklet of women's stories that are intended to encourage others going through the same thing. I have a copy of the booklet, and I was intending to put it with the little library stock here so that if anybody is interested, they can borrow that and have a read through it. The other lady who was supporting that group was Jan Manawright, and she works for the Prostate Cancer Research Institute and handles their helpline calls. So her contribution to the session was to answer questions and to give information where it was needed. I think these sessions are very worthwhile, and I usually attend if I can, both to give and receive support. The other aspects of the conference that I liked were the sessions where you could ask the experts questions. You could choose two that were most relevant to your situation, and these included various treatments, for example, radiation, chemotherapy, hormone therapy, and so on. I think I enjoyed them because since there's a broad spectrum of questions, the sessions cover a lot of ground, and you get the responses in the format of someone's specific problem. So for me, that's where I learn the most, is in seeing how a specific problem is treated. And the roundtable discussion at the end of the conference was similar, and again, covered a lot of ground with regard to the available treatments, which is encouraging. My overall impression of the conference, the letter of introduction that came with the conference package claimed that they had selected the most distinguished, cutting-edge, and well-versed experts in the field of prostate cancer research. And I think that that was very accurate. There was more information than you could possibly take in over the 3 days, and every effort was made to allow you the opportunity to access what was relevant to you. Apart from the specific information about hormone therapy that my husband has already covered, I was impressed by the advances that have been made since his diagnosis in 2007. I was also really encouraged by the attitude of the doctors and researchers who gave the talks. I think they're very dedicated. I think they're very keen on the work that they do. And it gives me hope that even better treatments are in the future, and that men who are currently living with prostate cancer can live longer and they can live a better quality life. I enjoyed the conference very much. I was very grateful for the opportunity to attend, and I can confidently recommend it to any of you who might be considering it. Thank you.
Well, thank you, and I'm going to bring this to some closure very quickly. My own history is actually history that I presented last year, and I'm going to give you simply a very quick update in the sense that I presented with advanced prostate cancer. And this slide tells the story. I presented with a PSA of 61 in February of 2007. It was determined that I had about 5 lymph nodes that were swollen and my bones were clear. I started androgen deprivation therapy with Eligard, and we added and stopped Casodex, and we added and stopped Avodart. You'll note that I chose a chemical therapy route because the cancer had escaped the gland. And so I needed systemic treatments. So I still have my gland, and I've never had radiation. So I've never had the side effects associated with those two therapies. But I do have the side effects associated with the drugs that I'm on. We added Zometa sometime in this period, and that was to build bone health. It was determined that I was slightly osteopenic, not osteoporosis. That's a more severe case. And for about the last 4 years, I've had an injection of Zometa once every 6 months. It's obvious that there was some rising PSA, and Dr. Ruther said, well, Stewart, your disease is metastatic. I said, I've got a lot of time. Let's get me on a research trial, because I'm not going to take chemotherapy this soon in my life. And I was fortunate to get into the Medivation 3100 trial, and was very, very fortunate to, and this is then pre-chemotherapy, and very fortunate to have been randomized to the drug. Why do we know that? Because PSA fell instantly. Within 6 weeks or so, my PSA was down at an extremely low level for myself, around 2.3. You'll see now that it's beginning to rise again. And in my last CT scan in December, the diagnosis came back that the lymph nodes, all of which had shrunken to normal, 2 of them were now beginning to swell again. And in the absence of any other convincing evidence, they would have to assume that this was, again, the evidence of metastatic disease. Let me show you another way of looking at the data. So this is PSA, simply in a vertical chart. What I've done in this next slide is to look at the log 10 PSA from a common point. When I was just on Eligard, the common point that I selected was 2.3 PSA. And likewise with Xtandi, the common point, my low nadir, when I went on to the Xtandi, was 2.3. And then I simply have plotted the log 10 PSA versus days after the 2.3. You'll see that there's a scatter of the line for the situation with respect to my Eligard and Casodex and Avodart and the beginning of the Zometa. But that scatter line is actually quite a linear line with a very high statistical significance. So that line is a valid line. You'll see that with the Xtandi that the line is somewhat similar. It is projecting out, it's increasing more slowly. The difference to reach a specific point, this number of 1.0 would be the equivalent, log 10 1.0 would be the equivalent of 10 PSA. We slide across here, and I come down to about 350 days. And if I slide across here, I come down to about 500 days. So there's a difference of 150 days currently at the rate at which my cancer is progressing under the combination of Eligard and Xtandi. So when Willem talked about a number of new new drugs that will be coming forward, at some point for myself, 2 to 3 to 4 years in time, we will again hit this point of 32 PSA. Hopefully my bones are still clear, and there's one of these other new drugs that are on the scene that I will be responsive to. So the concluding thoughts. I think this is a summary of everything that you've heard. The technologies are advancing quickly on all fronts, especially with respect to biomarkers, diagnostic imaging, focal therapies, and new drugs. There certainly is going to be many opportunities to merge treatment strategies across the disciplines. The discipline of the family practice, the urologist, who happens to be over in the foothills, the radiation specialist, and the medical oncologist, who happens to be over in Tom Baker. So we have some team building to do across these disciplines and also across distance. Those will be challenges. The treatment strategies are going to be evolving quickly, and there will be too many strategies to test at the same level of rigor as what we test today. Everything, all the combinations are not going to be able to go through a phase 3 trial. There is a trend towards more aggressive treatments earlier in the life cycle of the prostate cancer. So there is opportunity for clinical practice in Canada to become more entrepreneurial based on informed consent. I believe the best sequencing of therapies will emerge from clinical practices rather than from clinical trials. That's a fundamental shift in thinking. And that the funding models to accommodate complex treatment strategies are not yet clear at present. That, folks, well, I have one more slide. So essentially, for men like myself who never actually had primary treatment, or for men like Willem who's failed his primary treatment, and many men within our Warriors group who have failed their primary treatment, the key questions that they should be asking their physician is, what are we dealing with? How can we find out where the cancer is? What salvage treatments can we pursue? And how aggressively should we treat my cancer? And remember, each of us is different. This was already alluded to by Bob. So be sure that the treatment strategy is the right one for you. Next year, save the date. This prostate cancer conference of 2014 will be on the first long weekend in September, again in Los Angeles. Thanks very much. And team members, thank you very much as well.